Thank you, sir. It's nice hearing you after such a long time, sir. And thank you, Dr. Arun Gupta, sir, for inviting me for moderating this panel discussion. So, thank you. I'll just start. So, we had a great discussion today about various bone metastases present in 206 bones. Where all the possible mets can be there and how to manage. And as one of the statements by Dr. Gagan was very well said, that all of us don't have access to a dedicated ortho-oncologist. So we do have those challenges in our setting. We are not as lucky as CMH or AIMS, who have dedicated ortho-oncologists with them. So with that, so I'll start with, in non-metastatic stages, what do you consider a high risk for osteoporotic fractures? So, Dr. Pankaj, in non-metastatic stages, what all factors do you consider?
I
Whenever the
think
patient,
main thing is the usage of these steroids and underweight and lean body mass, history of fractures previously, then alcohol, smoking, and other factors you have enumerated, like this hypogonadism and impaired mobility. So these are the various factors we consider to have a patient for high risk of.
osteoporotic fractures. So, along with this, whenever the patient has a stage 4 disease, definitely the risk factors almost double or triple, because they have the tendency of having bony mets anywhere along the body. So now I'll ask Dr. Anil. So, what factors does influence in decision making in your OPD practice? So, number of lesion, does it affect your decision making, as which patients to be treated, which not to be treated, or bone targeted therapies need to be given?
So if you're asking about the number of lesion, I don't think so. The local therapy will depend upon the number of lesion, but obviously, is there any presence of lytic lesion, the soft tissue, and how much the patient is symptomatic from any of the vertebral side or the non-vertebral side, that will be most important rather than the number of lesion. Many a time the patient can have multiple lesion, but the patient can remain asymptomatic. So I don't think so that the number of lesion will be important for the bone specific therapy. However, it depends if you want to involve the nuclear medicine guys. If the patient is symptomatic and have multiple lesions, then it's a different thing.
Fine. So number of lesions will not depend. So basically, if you have even one lesion, then also you will give bisphosphonates or the denosumab, or if they have multiple bony lesions, then also you will give this bone modifying agents.
But I think
Yes.
the urgency of treatment would depend on that, because if this one subtle lesion maybe will not give that much importance, and after evaluating, whenever the patient gets a admission in routine, then we will give the injection. However, if there are multiple lesions, possibly on the first visit, I'll try to give the injection, so that at least the rapidity of response would depend on that.
So Dr. Arun sir,
Yeah.
sir, what I want to know, the site of bone lesions. So when do you want the oncologist, on which site of the bony lesions you want the oncologist to refer the patient to you? Is it the trochanteric, subtrochanteric? Is this the vertebra, or which area? When do you want the oncologist to refer the patient, so that you can intervene at the correct time and a good palliation can be achieved, sir?
So I would say any of the for palliation sort of, it all depends on the various factors, how the patient has presented acutely. Let's say, for example, the vertebral acute compression fracture. So these are the best patients who require possibly immediate relief, and as the rest of the modalities may take some time to give the patient a comfort. So in those cases, the IR techniques like vertebroplasty are the best where IR procedures will be best placed.
So
Rest, like some soft tissue and all, then you have to take a call that which modality maybe the radiation or surgical. They are so. I would say the vertebra is one side where if there is acute pain, then we are the best person to help the patients.
So Dr. Gagan, if the patient has suppose D4 vertebral lesion, he has pain and a soft tissue lesion, and so what do you want the medical oncologist to do? He should send the patient first to the radiation oncologist for treating the soft tissue area and for decreasing the pain, or should he send to the intervention radiologist for kyphoplasty and vertebroplasty? How does the medical oncologist or the surgical oncologist take that decision? So at what stage you want us to refer the patient and to whom?
Yeah, Dr. Sushant, of course, we are talking about creating a differentiation of referral between vertebroplasty versus radiotherapy. That is the premise of the question. So, first things first, when there is a soft tissue extension, the benefit of vertebroplasty becomes less and less. Vertebroplasty will be beneficial when there is some sort of a compression or some sort of a compression fracture as a result of, say, metastasis in the body of the vertebra. Generally, the soft tissue, when it happens, the lateral processes are involved, and that probably is not a very good case for vertebroplasty. But of course, each case is different. We are talking in a hypothetical scenario. There would definitely be some benefit somewhere which can be localized. So this is one situation that maybe vertebroplasty will not be of much help. It is interesting to note that very limited studies are there, but there was one Chinese study where they tried to compare vertebroplasty followed by RT versus RT. I do not mention it because there was a lot to mention in my in my paper, in my discourse anyway. So there was no difference in the terms of pain relief. But then vertebroplasty is not just about pain relief; it's also about structural integrity. So there will be some benefits sometimes definitely with vertebroplasty. But to answer your question, if there is soft tissue extension and pain, I would like you to refer the patient to the radiation oncologist so that the first pain relief can happen.
Fine. So,
I would,
Arun sir, do we?
just I have some difference of opinion with
Yes, sir.
Gagan.
Yes, sir. Yes,
Usual है sir, usual आपके साथ तो मजा आता है.
So it is a clear message that has gone by your words that if a patient have a soft tissue lytic lesion, then the vertebroplasty is not going to benefit. I completely disagree with that. See, in fact, the lytic lesions are the best lesions for doing the vertebroplasty. Kunal, if you want to comment, because you do a lot of vertebroplasty.
Yeah. So, Dr. Kunal, if you are there, please guide the medical oncologist like me and Pankaj when they have the patient. So, whom do we refer? Do we refer to the radiation oncologist? Do we refer to the spinal surgeon? Do we refer to the interventional radiologist? That's why I've put all these names in the DMG. So, Dr. Kunal, if you're there.
So first and foremost, if there is a soft tissue, we can do ablation followed by cementoplasty or vertebroplasty, and we can reduce the acute pain instantaneously.
Sorry, I'll just interrupt. Ablation, what do you mean by ablation?
RFA or cryoablation or microwave ablation, depending on the what modality is available. We burn the tumor, we create a space, and then inject a cement. So that will cause a structural integrity as well. And if there's acute pain relief with vertebroplasty is much higher than with radiation. Radiation has an effect over a weeks to months for having the effect, as compared to intervention radiology, which is instantaneous, almost less few days.
So if I want to rephrase, if the patient has impending spinal cord compression,
so then it is a surgery.
Then it would be a surgery.
Yeah.
If there is
less
the
than
soft tissue component which is not impending on the spinal cord, and the pain is there and soft tissue component, you would like to ablate and then do a kyphoplasty
and followed by radiation.
And followed by radiation.
Yeah.
So Dr. Anil, would you agree? Sir, sorry, please carry on.
Just a second. To summarize this, the thing is that if the pain score, the VAS score is reaching like 8 or 9, then I think one should give the benefit of the vertebroplasty in spinal mets patients. If the score is, I would say, 5 or 6, possibly because the better tumor control would be with radiation as compared to ablation and vertebroplasty. So like was for like 5, 6, I would prefer sending it for the radiation.
If I may add, actually, there are certain parameters on the basis of which it is decided whether surgical intervention is required, like the depth of the bone which is involved, then also whether the mobile part or immobile part of spinal cord is involved, then the number of facets which are involved, how acute the presentation is, whether the neurological deficit is just going to happen or not. So there are various factors on which basis of which it is decided whether patient go for surgical intervention or non-surgical, and also the longevity of the patient. So longevity, site of spinal cord, extent of involvement, number of facets involved, all these factors are important.
So Dr. Anil, would you agree or you want to add something?
No, I want to add something here. There is no head-to-head comparison that we are aware of. The recent head-to-head comparison between the intervention radiology, like the vertebroplasty versus the RT. However, I beg to differ. The immediate response of the radiation therapy is not in the month of 7 days or month. You can expect the response by the beam of external beam radiation therapy. If you give SBRT, it can be as early as 1 or 2 days. Even with the soft tissue, the radiation therapy will give you a better and durable local control as well as the durable pain relief. So if you see the various new randomized control trial by Dr. Sehgal, where they have delivered the SBRT in any of the site with the soft tissue, with no soft tissue, with the lytic metastasis, the duration of the pain relief is close to 6 to 8 months. And the pain response, the complete pain response is close to 40%. So here we should not debate about the choice between the interventional radiology versus the radiation oncology. It's about individual case scenario. If, for example, EBRT has certain advantages. It is non-invasive, pain-free. Okay, so these are the two most advantages of the external beam radiation therapy. Obviously, if the vertebral height is less, if there's vertebral collapse, obviously interventional radiology will help in a much better way than the external beam radiation therapy. So I think we should take a balanced view and we should take an individual decision.
If I may make a comment, Dr. Sushant,
yes, sir.
That the spinals, the score that Dr. Pankaj has mentioned, it was there in almost everybody's slides, I think, that it's about spinal stability. So this is a separate matter. Soft tissue causing pain is a separate matter. Vertebral collapse is a separate matter. And spinal cord compression is a separate matter. These are slightly different aspects of bony metastasis. So if you have a vertebral collapse, vertebroplasty is good. And if it is causing pain, the pain relief is great. If there is soft tissue, I beg to disagree with Dr. Gala that whatever your ablation is going to be there is not going to work that well, because the soft tissue is not just in one place, and that area of neural complex is that neural area is very complex. There is a lot of diffuse infiltration. You won't be able to ablate. You will have to send the patient for radiation. Each and every study with vertebroplasty has been followed up by radiation. Yes, they have studied the pain relief and all, but then eventually patients have gotten radiation. Please, as Dr. Tiblewal has said, the benefit of radiation is very, very, very quick and is very highly time tested. It's been more than 50 years radiation therapy is being used for palliation of bony metastasis. And we all have extensive experience. Nobody is waiting for 4 weeks for pain relief. Maybe the patients come to the interventional radiologist in that way. Those patients are coming. So maybe that is why this island of experience is happening. But in general practice, the benefit occurs quite quickly. If I'm doing 10 fraction radiation, by 4th or 5th fraction, the patient is telling me that the benefit has started, at least in 25 to 50% patients, if not in all. So, but yes, if the spine is not stable, spinal stability is paramount, because no matter what you do, you will get one fracture or the other. So that is a separate aspect to be fixed. I hope I'm making sense here. I hope I'm addressing all the aspects in a very objective manner. So radiation therapy is very important. Vertebroplasty is very important. And, certainly surgery is very important. decompressive surgery is questionable in the absence of a very trained and a surgical, ortho-onco surgery.
Fine. What is the message we are trying to give? Is that we need to discuss in the DMG and then
Yes, of course.
decide what is best for the patient. The neurosurgeon, the spine surgeon, the interventional radiologist, all have to be there, and then decide whether the surgery followed by radiation, whether the kyphoplasty followed by radiation, or radiation upfront. Whatever is to be done has to be done in keeping the good faith for the patient. So now the next question, what I am asking, like Dr. Agarwal had mentioned, in which scenario we would not like to treat the bone mets. So I'll give you a scenario. We have a patient who has headache, persistent headache, CA lung patient, and we did an MRI, and it showed that there was a dural bone met which was on the parietal bone, which was causing the pain. So would we like to treat with by radiation, or would we like to just do a medical management in such patients? So Dr. Anil, what is your take on such patients?
So Sushant, it's a very nice scenario about the dural parietal bony metastasis.
We
Here there are
commonly
two.
get such headache
Yeah.
patients.
So here there are two scenarios. If the patient is having persistent headache because of the dural bony metastasis, I think first and the foremost will be the medical management. That is the analgesic. We give a trial of analgesic for at least 7 days. If the patient is controlled on analgesic, we delay the radiation therapy and let the medical oncologist start on the systemic therapy, see the response. If the patient is not having any relief with the analgesic trial, then we should give local therapy, that the radiation therapy, to have the effect on the pain relief.
Fine. So Dr. Gagan, would you agree with it, sir?
Yeah, I mean, if it is not working, I'm sure they will be using the medical oncologist. You, Dr. Shant, you will be using the bisphosphonates and all. I think something or the other will work in this sort of, because this type of ribs and these type of things we don't always treat unless it's beyond the benefit from all the other therapies. So we won't treat that.
So basically, whatever can be treated by drugs or WHO pain ladder system, will try and do that. And in such metastasis, radiation would be kept in the last. That's what we agree on.
So we have had a patient who had midline shift because
of the bony met.
Yeah.
Yeah.
Large
Soft
And in that scenario, if there is a pressure symptom, then I don't think so that the analgesic will give you a pain relief so better than EBRT. So in that scenario, you need to have the local radiation therapy for reducing the symptomatic, for reducing the pressure symptoms.
I agree. Nothing to disagree. Absolutely. If it's causing, if the component inside the inner table is causing so much soft tissue that it's having midline shift, then so it's imperative to give radiation right away. Probably the first thing that you should do is that.
Now, my third scenario is prophylaxis. Now we have patients who have had pain in the pelvis and there is a subtrochanteric lesion which is present. So would we like to treat that patient if he has the pain score is just about 3 and 4, which is being well managed with Ultracet and Mobizox and all those painkillers we are able to manage? But would if Dr. Arun Gupta sir, would you like to intervene in such patients at present?
I don't think so.
So no, interventional radiology will not have any role. So radiation oncologist, Dr. Gagan, would you like to interfere in the weight bearing area, which is there? There is mild disturbance in the quality of life. So would you like us to send the patient to you for the
Yes, please. Yes, please. So if the bone is not highly threatened for pathological fracture, then we give radiation therapy. And that radiation therapy, due to its effect on the tumor cells and of course the local effects, it leads to an early bone remodeling, and that leads to strengthening of the bone and decrease of the skeletal related events in terms of bone breakage and so on and so forth. So yes, radiation therapy to weight bearing areas is very important.
Now, sometimes I get confused with the clavicle or the acromion. Do we consider it as weight bearing, or is it just managed to be with
Clavicle is yes, it is weight bearing, but it's not bearing a lot of weight. But acromion is very unique that way because the moment you move your arm, you will get pain when you have acromial metastasis. So it's very irritating, these scapular and acromial metastasis. So I would say that for the sake of pain relief, these patients should be getting radiation therapy. But these are very tricky areas. One should be very careful. Use 3D planning and everything. Otherwise, don't do it. Otherwise, if you don't have 3D planning, if of course all of us have 3D planning, but if somebody doesn't have it, don't use it because the lung toxicity will be huge if you don't do it properly.
So, Dr. Arun sir, I want to ask you, what all are the indications when the oncologist should send the patient to you in case the patient has pain? So, what all indications are there, sir?
So, if see the peripheral parts, like I said, I think these are well easily managed by medications, as well as possibly the radiation has a better role. So in my opinion, if the patient is having fracture and acute pain, then for immediate relief of pain, the vertebroplasty should be offered, followed by radiation therapy. And like if there is some issues like some soft tissue peripheral lesions are also respond well to the cryo, soft tissue lesions like ribs and all. Here cryo has a very good role, nearly painless procedure and well tolerated. So those are the cases where cryo, so thermal ablations only with cryo with the soft tissue parts are preferred modalities to treat these patients.
So celiac axis block, brachial plexus block, you also do it, or only the pain specialist does it?
Celiac axis block, IRs are doing.
You are also doing. So, sir, what are the indications for celiac axis blockage? When should we send the referral and what stage?
So celiac. So I think if it is not controlled by the medical management, those are the cases where the celiac axis blocks can be offered.
Can be offered. And when you counsel the patient, sir, what do you counsel? It's the success ratio 60-70%, or
definitely.
And it will remain for about 3-4 months or
yes.
6 months.
So this is the truth, and we have to tell the patient the truth about this.
Okay. So, Dr. Kunal, would you like to add anything else for telling us when all we can send the patient to you? At what stage should we send?
So another thing is where the acetabulum, the pain in the pelvis, like the acetabular roof, which needs to be reconstructed because of limping or the metastatic to the acetabulum.
Okay. So I think we have had enough discussion for the emergencies, the prophylaxis, and the routine cases. With this, I'll thank all my esteemed panelists for a wonderful discussion. Dr. Gagan, yes, sir.
Dr. Sushant, I really am very curious about Professor JP sir when he asked that is there a different dose required for nitic or sclerotic metastasis when he said the bone rolling. Yes. If Professor JP sir can just lift the curtain off that question.
So JP sir, over to you for the remark and the remark.
Okay, so the question was, so when we are going to do in a mixed setting vis-a-vis in a sclerotic setting, we need to define very carefully when we deposit our doses. So in a complete osteolytic doses, the doses don't get deposited in the central part. So we need to be very, very careful when we do the planning, especially when we are doing a high dose irradiation. And definitely bisphosphonates, etc. are important. And also we should be very careful about the vertebral fracture, especially when we are treating with the high dose radiations like SBRT. So at that time, sometimes it becomes tricky when you are using with a high dose radiation. So my colleague Kunal and all comes to our rescue at that point of time. Lastly, I want to say that please don't forget the toxicity. We need to take care of the toxicity, be an invasive procedure, infection, etc., or a spillage posteriorly. So we have to be very, very careful and do a judicious work. So the pain or the symptomatology is alleviated, mitigated as quickly as possible and effectively, as well as without toxicity. That should be our ultimate aim. And Gagan and everybody, I'm so thankful and grateful to you all for keeping me on my toes here. And back to Arun. Anything you want to wrap up the whole sessions?
So I think it was a wonderful session, and we have a good discussion. Even I learned a lot of things. And so first, I would like to thank this Academy of Lung Cancer, who is doing this wonderful job of all the issues related with the lung cancer. I would like to thank the chairpersons, Dr. Pavitran, Dr. Shyam, Dr. JP Agrawal, and also our very nice speakers, Dr. Priya Tiwari, Dr. Ashish Gulia, Dr. Kunal Gala, and Dr. Gagan. And also special thanks to Sushant, who has taken, we have given him this, offered him this to run this panel discussion very late, and he has accepted it and did it wonderfully. And also all the panelists, Dr. Pankaj Goyal, Dr. Kunal, Dr. Anil, I thank you all. And possibly after, we'll see you all in our next webinar. Thank you.